Please help me in welcoming Breiane Jackson.
I am Breiane Jackson. I have been a pharmacy technician for 17 years now. I thought that it was just going to be like a pass-through job. I have made a lifelong choice and career out of it. And I don't think I knew when I first started what I was getting myself into. And I think that probably was the best because I probably would have gotten away of all the things that have happened.
Pharmacy is not a job, it's a profession.
It is a profession, and every year it grows. Because 2 years ago, I believe we were in I sat through the entire conference 2 years ago in Nebraska, and we had a session where they were talking about how pharmacy technicians can now sit on state boards. And since then, there have been, I think, a few more states that have added. So this is definitely a big career pathway. And when I was plopped into pharmacy as a closing shift technician without any guidance, I got nobody to help me. I remember crying at the drive-thru like, what is a PRN? What is that supposed to say? But talking to the pharmacist, I never thought that I would be to this point. So thank you guys for being here. I'm so excited to be with you. My career has shifted from being at a commercial pharmacy. Now I actually work for in the Medicare Advantage space, and seeing the two collide helps me to understand how much of a difference pharmacy technicians do, not just for the community pharmacies, but our patients that are trying to make sure they can afford their medications through their Medicare programs, right? Okay. All right, so we're going to talk about medication reconciliation. Again, I'll go back to my original statement. When I became a pharmacy technician, I thought being in a commercial pharmacy was my only option. I never knew that I would actually end up at an ED. I worked in the emergency department doing medication reconciliation. I never knew how big of a deal it was until now. All right, let us start with an icebreaker, something fun. Tell me the funniest way a patient has explained to you what their medication is. We've all heard the little football, the white football, right? I've also heard of the yellow bars. You know those bars? Yeah, I know what you're talking about, but how many you need? I don't think I'm going to be able to give you 450 today. Yes.
When I did retail pharmacy, a guy would come in once a month, and he would come to the counter. He's kind of looking around, and he goes, I need that one pill y'all give me. And
We're like, can we start from the beginning?
One. And he was like, I don't know the name of it. And I'm like, do you know what it's for? He goes, it's my dick. So then it fell, but every month.
Every month. Same thing. And it's like, I know you remember this conversation we had last month, sir. I told you today. Did you write it down somewhere? Any others? Any others? I've always heard, can I get the inhaler, the blue one, not the yellow, not the orange, or can I have
Eye drops.
Or can I have the medication that me and my dog take, the phenobarbital? I give it to my dog, but I also take it. I'm like, okay, we're going to have to like narrow it down. But we've learned in the space as pharmacy technicians that we are also investigators. We actually have to ask the right questions so we can kind of guide our patients into telling us what the truth is versus what they think. Because we all know atorvastatin doesn't just roll off the tongue, unless you've said it 500 times. Atorvastatin, we've heard that one. Everybody knows clear name for Xanax. That just rolls. Now that one rolls off the tongue, but other medications that seem to be the most important medications to our patients don't just roll off the tongue. So we do have to spend a lot of time deciphering. On top of deciphering these prescriptions that used to be handwritten. I haven't seen a handwritten prescription in a very long time. But if you've been in the space long enough, you know it's scribble scrabble. So we just kind of spend a lot of our times being that investigator. All right, so today we're going to look at identifying common medication discrepancies in Medicare populations and explain how they impact that adherence, quality measures, and then patient safety. Analyze how pharmacy claims data, benefit design, and formulary structures influence medication reconciliation outcomes in that health plan setting. And then apply our pharmacy technician skills and our knowledge to improve coordination between health plans, medical groups, and members or patients to reduce the medication-related gaps in care. Okay. All right, ideal landscape. We have a patient who uses one pharmacy, right? One doctor writes all the medication. Then we got no Part B or Part D rules. Any type of OTC or supplements come directly from their one provider's advisement. They actually go directly to a pharmacy to pick them up with the list, and then everybody talks to each other. Ideal, right? That is not the reality. And we have a patient that has 5 or more medications. That's technically polypharmacy. Actually, 43% of our U.S. adults that are 65 and older, they have that polypharmacy. They're taking 5 or more medications. We don't always see that one provider is writing all 5 prescriptions, right? So who's talking to who? How are we getting this information from our PCP to our specialists? How do we track when they're going to urgent care? And the urgent care is not connected to the MyChart where their PCP is. So who has the correct information, right? We know that the Part D and the Part B rules are ever changing. I don't know who does billing at this point, whether you're in a commercial pharmacy setting or you're working for a Medicare Advantage plan or what setting you're in. The billing changes every year. And then if you've been in the space long enough, you know, I know how to do the back end. I know how you're crossing out the actual price, you're putting 0 because you did some back billing. It has been scary and crazy on our behalf, but we present it to our patients like everything's taken care of, right? Okay, so what's at stake? Then we have adverse drug events, hospital readmissions, increased patient harm, and then patient confusion and trust, right? So it's not about the accuracy of what our MedRecs look like. It's really about the outcomes, right? So more than 1.5 million people visit the emergency department for adverse drug interactions, right? And that's actually more than 600,000 of these visits are from our older adults. 600,000 is a lot for adverse reactions, and it has a lot to do with the confusion and the lack of having a clear picture of what they're taking, right? Right. Oh. Common medication discrepancies, omitted medications. So these are the medications that they forgot to tell us about. They don't have the bottle. It wasn't on the list. It was just added. Oh yeah, I've been taking this lion's mane for 9 years, and I just tried this turmeric. Not saying those things are bad, but to get a full picture, we're relying on patients sometimes in their most fragile moments to remember everything that they're taking. And if we're looking at 43% of the population that are 65 and older taking more than 5 medications, how do we expect them to remember that, right? All right, duplicate therapy. Our patients don't know if their blood pressure medication changes. They have to stop the one they were taking before. Or, hey, we've got to titrate this down. Or, yeah, if we're not clearly communicating, and when I say we, that's everybody on their care team. It's not just the provider, because human error. Doesn't matter how much we've learned. We got some human error, right? It happens to us all the time. I have sold the wrong medication. Human error. Did it 15 years straight in a commercial pharmacy, and you always remember the one, don't you? Where you're chasing somebody down in a parking lot, and you're calling them like, don't take it, I'm sorry, you got the same name. So if we know that we make mistakes, and we've been doing it a long time, we have to give grace to others, but in the middle, our patients are the ones that are the most impacted, right? Right? Incorrect dose or frequency. So it changed from twice a day to once a day, or it changed from once a day to 3 times a day, just for that week, because how do they know to change that? If the doctor just makes a phone call or leaves a voicemail, or they're putting it on MyChart. I don't know about y'all, but my grandparents don't know how to sign into MyChart. They don't know what that looks like. So if the nurse or a provider leaves a message and say, hey, check your MyChart, I made some changes, that's not going to roll over well, right? Then we have medications that are no longer taken, but are still listed. Oh no, I stopped that months ago. How many months? Not sure. What were you doing? Was it cold outside? Was it warm outside? These are the type of questions we have to ask as investigators and saying, how long ago did you stop this? Is this why this looks like this? Are you taking these two together? That. Medications prescribed, but never taken. I can say, you've seen that, right?
A lot of that.
A lot of that. It's at home. It's still in the bag. My grandfather picks up his medication faithfully. But as soon as he rips off the leaflet to read the side effects, medication is still in the bag. He has decided, no thank you. I said, that's not going to happen. Just, nope, I'm not taking it. But it's listed.
You're here for AFib. You were here for AFib 3 months ago. You picked up the medicine
You did not take one pill.
because it causes side effects.
Because it causes side effects. Over something that they've read versus we're like, hey, we have to do a risk analysis. If you don't take it, then what? But in totality, we have to be very, very much so true to who we're dealing with and who we're talking to. It doesn't necessarily matter the age. So it doesn't have to be our 65 plus. It's anybody. You get your hands on a leaflet. In worst case scenario, they read that very last line of side effects where it gets to be the worst, and it's like, oh no, I'm not doing it. But it's still listed on their medications. So this whole time, every provider that they see believes if they've taken this medication. It's not the case, right? All right, so has anybody ever done MedRec here? Tell me what you've seen what's the first thing you say when you're about to start your MedRec?
Oh man, the first thing I say?
So how are you getting them to tell you what they take?
Well, I mean, I had asked them first if they had a list, but then I would, even if they're like, well, it's in the computer, everything's right, I'd be like, well, yes, I know, but for your safety, we're still going to just go over everything. I have lots of questions.
Mm-hmm. What about you?
So that's actually what I do for my day-to-day.
Mm-hmm.
So I try to start off by just telling them that I have a list. I can work through it with them if they need help with, what it's for or what it does.
Mm-hmm.
But I would like them to tell me as much as they can.
Yes. Tell me what you actually take versus what I see here. Anybody else? Yes. Oh, were you raising your hand?
Mm-hmm.
Yes.
I mean, first thing I do is I introduce myself. And a lot of times, since I do work in the emergency department, the first thing the patient will say is, I've already told 2 doctors. And then I just try to explain, this is our way for check and balance, just making sure what the doctors wrote down, which is so not really accurate, but what the doctors wrote down are match with what the pharmacy have. So we're just doing this to be safe. And then they tend to be a little bit more open. So.
Yes.
When the patient will, because I'll answer the phone for them to call in to fill medications, they'll just tell me to fill everything. So I will intentionally go to a date of a medication, say August, something that they're probably not taking, and they're like, no, just fill everything. So I say something from August that I know they're not taking anymore, and they're like, I'm not taking that. And then they'll take me seriously and start reading off the medications that they know that they need.
See,
I bait them into it.
No, that's really, really smart. Kind of think back. Can anybody on Zoom, if you want to put it in the chat, I'd love to interact there. If you have any ideas of how you start your med recs, or when our patients call in, how's that go? Me in the emergency room, especially if they come from the ambulance, I get a whole grocery bag.
Mm-hmm.
I'm putting on gloves because
Yes.
everything is everywhere, right? And the medication bottles are from 2 years, from last year. I have 2 full bottles of gabapentin that look like they haven't been touched. I have Usirodol. I have 10 bottles of that because it comes in a bottle this big and you got 360. Have you taken? And you just kind of look like, okay, can we start from square one? What did you take today? What did you take yesterday? What have you taken in the past week? So we can kind of work backwards and what the real picture looks like, right? Or you get this pretty nice list that's like completely laminated, right? And it's like, when did you do this? Last year? Has anything been added? Or taken off because it's laminated, so I know you can't do anything with it. You know what? You're right. That may be from last year. And it's the best intent. Our patients have the best intent. It's just their intentions are really good. It's just hard to keep it all in one place, right? So unless they have their cell phones and they have all their my charts, in order, or you do have patients who know line for line what they're taking and what they are not, don't we? We have those. But then you have patients like, can you talk to my wife?
He does it himself.
And then the wife's like, I don't know how I'm gonna keep up with mine and his. And they're doing the best they can, with the best they can with what they have. But the picture is what? Unclear. So here we are. A med rec that could take us 10 to 15 minutes. We ain't here for an hour. And it's necessary. It is necessary when they are coming, because they don't feel good, right? All right, so we have this handwritten medication list, that last discharge summary from the last time you were here 2 months ago. This is what they said I took. And you realize sometimes the med rec wasn't done, or they just printed off something that was old. That try that med list by memory. Ugh. And then when you finally see the med list, you see the donepezil, and you're like, oh, this might not be as clear as picture as I thought, right? And then we have medication bottles. You open up one bottle, it's 3 different color pills in it. Oh dear. I've had to do that. I think I've spent hours with a pharmacist because a patient put all of her medications in one bottle. One bottle. So we had to go down the line. Y'all remember those big pharmacy books that they had with the pill picture in it? We were getting hours because we needed a clear picture, right? So what's actually happening is what medications are actually being taken, meaning ingested. Not what's in your container or that your caregiver puts into your weekly, beautiful, colored, coordinated container that you still don't touch. Right? I think I'm to the age now where I need one of those to put my vitamins and stuff in, but I'm just saying, I know where to get it. And then changes over time. So cost and access may change. Something may change in their medical history. Maybe they are hospitalized, so they can't take the medications or pick it up from the pharmacies. So it just seems like it's incomplete, right? Most of the time. So the anatomy of a pharmacy claim, I think most of us here have seen some sort of claim, right? We've seen some type of billing. We're looking at NDCs, the quantity, the day supply, right? What the plan doesn't see is the side effects, the confusion that our patients are having, and then whatever leftover medications they may have. Or financial anxiety, like I got enough for this month. I'll make them stretch if I have to so I can buy food next month. We've seen this, right? And then the trap, the claims data, it's looking at what's being dispensed, not actually with the consumption, right? All right, and then there's that formulary domino effect. January 1st comes, all craziness breaks loose, all the formulary change, that tier 1 is now a tier 3. Half of the patients don't understand what that means. They just know when I come pick it up, it's not the same price. I'm not picking it up anymore. Right? Or you're going to get them picked up twice a year because they absolutely need them at that point. Right? And then the stash. I'm going to hoard this medication just in case I'm ever going to need it. And then you've stored it in the wrong place. You forgot about it, or you take it when you think you need it. You're not even exactly sure what the medication is for. Right? Right. All right, got a case study. This is completely made up. This is not HIPAA information. I made this up. We can actually use my grandfather, but we'll go with Mr. Frank because this is pretty much the same story. So, Mr. Frank is 74-year-old. He's a 74-year-old male, Medicare Part D beneficiary, right? Type 2 diabetes. January 1st, he had a formulary update. So, his Farxiga is no longer preferred. So, that's fine. Jardiance is. We'll switch it. So the provider just takes the initiative. I am going to switch the medication. I don't need to let Frank know. The pharmacy's going to call and let him know when it's ready. So what does Frank do? What we see at the pharmacy is that on 11/15 he picked up 90 days of Farxiga, right? If you look at this pharmacy claim, you can see it's all staggered. Why are we not getting everything at one time? But that's another problem for another day, right? So Farxiga is picked up for a 90-day supply. January 5th, 2026, right? Jardiance is filled for a 30-day supply. He picks it up. Does Frank know that Farxiga and Jardiance are in the same class? Absolutely not. He said, oh, I got a new medicine. So what is Frank going to do? Frank's going to do both. Doctor never told me to stop. He never thought to ask the pharmacist. we're filling the medication, and as soon as you ask, hey, Frank, do you have any questions for the pharmacist? No, I think I'm good, right? Because he's out the door. He's trying to go grab whatever he needs from the Walgreens or from CVS or wherever he is. He's trying to get out the door, right? But when he goes home, every day he's been taking his Farxiga. Nobody told him to stop his Farxiga. Now he's taking his Jardiance. Oh, the pharmacy claim looks right, though. Everything's together. He didn't have a gap. Everything should be fine, right? No. Nope. Patient safety. Now Frank has severe dehydration, dizziness, hypoglycemic, and then fall risk. He feels terrible. He can't tell which one is making him sick. Guess what? I'm done. I'm not taking anything. Have we seen that? Oh, I stopped taking all that. We're calling him like, hey, it looks like you're automatic. Why aren't you picking up your medication? I'm done. I'm not taking anything. You think he's going to call and let us know? We do know some people will call us and let us know. But most cases, that's not the situation. We just realized when we haven't seen Mr. Frank in a while that he's not taking, like, hey, what's going on? Are you okay? And then we find out he's in the hospital. Because it's not anything that we did. The pharmacy claim was right. It's just a miscommunication. And all the cross-functional work, right? All right. Next, let's meet Miss Martha. I don't know if anybody was here 2 years ago. I know you were here, Roxanne, 2 years in Asia. When we did, when I was in Nebraska, I did speak on the patient assistance programs, and I talked about the donut hole. Y'all know 2026, there's no more donut hole?
Yeah.
Isn't that wonderful?
Unless they change the rules,
Unless they change the
because
rules.
they're planning on it.
Don't change it.
No, that's exactly what I'm
They're
getting.
they're talking about rolling back that, and it'll go back to pre-levels again.
And I actually put this in my presentation about talking about the coverage gap, and I knew that it changed, but in all these years, it makes me nervous. That's what I'll say. And that's where that sticker shock comes from. So let's meet Miss Martha. She has COPD and asthma, but she ended up falling in the coverage gap. Or middle of the year, her medication goes from a tier 1 to tier 3. For a Medicare plan, we do have to give advance notice. How often you, like, statistically, how much do you open your mail? Let alone them opening the mail and then not understanding what a tier 1 to a tier, we don't even know how to read the medication. So we're realizing, we sent her out a letter to tell her that her inhaler is going to change, right? The tier. She doesn't understand that. She shows up. She got her Trelegy at $47. Right? 2 months later, it's $215? And we did give her advance notice, but that didn't help. That's not helping her to save the money, to prepare for. So what does she do? She doesn't pick it up. Doesn't pick it up. All right. All the stories are just, it seems like a never-ending negative cycle, but that's where pharmacy technicians come in. Because when we catch these things, this is where our relationship with our pharmacists and our knowledge with the conversations that we overhear, because I don't know about y'all, but I think I'm the master over here. When you're listening in on how the pharmacist conversation is going with it, I think that's how,
I need to separate my pharmacist from that person.
Absolutely. Did they say our trigger word? Do I need to come save you? Or you know when to take over? Oh, you know what? Thank you. I'll take it from here. I think
got a phone call.
Yes. Yes. Hey, I need you to verify this right quick. We kind of know when our pharmacists get. I think that's just a part of the role. All right, medication reconciliation across the settings. So we have a hospital setting, we have that health plan setting, and then the community pharmacy setting. Like Jacob said, when he answers the phone or when he's calling the patients, and then they're asking for every single refill. Then we were talking about the hospital medication reconciliations. Are you doing yours in the hospital? Yep, at the ED, you have to do it there. And then in the health plan setting, where our pharmacy technicians, when they're in specialty programs, we do have to do a med rec, right? So with just these 3 settings, how much overlap happens and how much missing happens? Where does it fall through the cracks? So we have the claims data that we all can see, but then we have to take in consideration what we can't see. So that's where that cross-functional and that communication happens, okay? Here's that detective work. We want to match claims to reality. So we want to compare the data from our health plans to the patient's physical vitals. And if you're in the hospital setting, we can actually call pharmacies. So I don't see your name. Megan. So if Megan, doing her Meg rec, could call Jacob. Hey, Jacob, when was the last time Mr. Frank filled his X, Y, and Z, right? So two pharmacy technicians speaking to each other to close the gap, even taking it a step further where you may call the urgent care that the patient went to where you can't see in there. It's us digging to find and asking the right questions, right? Right? And then we identify the why. Hey, Mr. Frank, what happened? I see you haven't picked up your Farxiga in 2 months. Oh, it wasn't making me feel bad. Okay, that makes more sense. That's why you're here at the hospital, right? Or Mr. Frank's calling you. He's like, hey, fill everything. Mr. Frank, you haven't taken this. Or this changed 2 months ago. I didn't know that. It's the conversations that you kind of have in asking other questions. And then we want to move beyond the are you taking to show me. So if your patient calls, asking to fill everything, hey, read off what you have on your empty bottles. That's what I know you're actually taking. That's what you want. Versus fill everything. And not only are your bins full and they never pick it up, patients don't even know what they are. They're just swallowing pills. You know what I mean? All right, some scripting to catch our interventions. So for Mr. Frank, I see you filled Jardiance recently, but you still might have some Farxiga at home. Can you read me the labels on your bottle that you used today? What did you take today? Or what did you take yesterday? This way, he has to actually put eyes on what he has and read them out. Then we can have that conversation. Mr. Frank, these are in the same drug class. Or you need to come in. Let's let you talk. You need to come talk to the pharmacist so we can talk about what you've been doing and what needs to be done moving forward, right? Or for Miss Martha. Hey, Martha, I noticed your inhaler wasn't picked up. I know it's expensive, and then navigating those costs can be frustrating. But let me get you to talk to the pharmacist about some alternatives. Let's talk about something different. We don't want you to miss that. You need that, right? And if you know, patients that come to their one pharmacy, sometimes they really just coming to see us. That's all. That's really a big catch of it all. They don't get out, but one time a week, they come see us, even if they don't even have prescriptions to pick up, because they just want to hang out, right? So that's our opportunity to close those gaps, right? All right, overcoming health literacy barriers, right? We always want to bring the level down. When you're talking to Mr. Frank, when you're talking to Miss Martha, we're not going to over-explain or use the big words. We'll meet them exactly where they are. Your sugar pill, your water pill, then we spell it out to them. So we're giving them, it's accountability. I'm going to start spelling it. You find that bottle with those letters on it, right? Or you start spelling it to me, right? Or we can rely visually if that's necessary. But I don't know how many white football-shaped pills are out there. I don't know if that's going to be the best bet. But if it's something that is different, then we can go there, right? And our goal is always, without talking down to our patients, we want to make sure we meet them where they are, right? And that's where the trust comes. They start oversharing about, like, that pill. All right. So we want to bridge the gap in care coordination. I think this is just kind of our thing. Let's just say this is our thing. We know how far, as pharmacy technicians, we know how far our conversations can go before it's time to do the handoff. Oh, you're starting to talk. Give me 1 second. Let me get the pharmacist for you. I can refill. I can answer very lightweight questions. Do you want to know what's on aisle 7? Yes, I can tell you that. Do you want to know the cost of something? I can tell you that. But are you trying to ask me about complete interactions of 5 different medications? Could I Google it yet? Yes, but I am not. Let me get to the pharmacist. We know when to do that handoff, right? Right.
I tell them, when you talk to the pharmacist, I think they could give you some helpful hints that may help you be able to take this medication a little bit better.
A little bit better. Yep. Mm-hmm. That is very, very true. It does feel like this picture sometimes, though, doesn't it? So we have to get the patient to understand, to the pharmacist who has a vast amount of knowledge, where I don't know about y'all. I've worked with a lot of pharmacists, a lot of pharmacists. And sometimes I'm like, not that word. We can use those words. I need you to bring it all the way down, and it's not because our patients are smart. It's that don't want to cause any further confusion, because to be kind, they'll nod and say, okay, and then we'll either never see him again or that same confusion is there.
Or they'll make sure that pharmacist isn't there.
Yes, they will come to you. You've seen it.
I don't want to talk to the guy. I want to talk to the lady, but not the older lady. I want to talk to the younger lady.
Yes. That is always the thing. I have heard some things. The way that the patients that we have who see us regularly, how they describe us to other people, or they're describing the other people that we work with to us. It's kind of like, you were kind of spot on, or I have no idea who you're talking about. All right, that tech pharmacist synergy. I think I have some of my closest friends, mentors. My number one mentor is my first pharmacist of all time. She became a family friend. I ended up taking care of her children. They are now in college. I ended up having twins because she had twins. I have twins now. And I'm like, it's because I worked with you. She got me my first pharmacy job. And I thought it was just going to be like a little throwaway gig. But to mention, that synergy is a relationship. We're spending so much time with them. We eat lunch together. I don't know about y'all, but I remember stepping into work at 8 o'clock in the morning and be like, what are we eating for lunch? That was the goal for the day, right? That was the goal. But we as the investigators, we gather the data, we build the rapport, and then we identify the mismatch. So when we do fill in our pharmacists, who are our people for that day, I used to remind one of my pharmacists, I'm like, you know your anniversary coming up. Did we order a gift? So his wife would be like, where's our work wife at? She was also a pharmacist. But we knew how to communicate. So with that relationship, we are able to do that smooth handoff. To have those conversations about the patients. Sometimes we have our ways of explaining things to our pharmacists so they can understand how to explain things to our patients better. But I think that synergy between our patients, our pharmacists, and kind of that footwork. You ever watch a pharmacy flow and it just feels like a dance? It's something you never forget. I actually stepped away for 3 years and came back, and I was like, I just tapped 200 prescriptions. It didn't even feel that way. It was great. It's just like something we don't lose, right? And then we want to make sure that we're working up to what our license says, right? We do have pharmacists and our pharmacy technicians in states that can do the verifying prescriptions. We have technicians who can go up to some limits. Here in Georgia, we can get vaccines, but we haven't gotten to the verifying yet. And that's okay. But we just want to make sure that we are only practicing up until what our license is allowing us to. And then we want to make sure we have that smooth handoff, okay? All right. When we speak about our examples here, Frank and Martha, when we're doing our med recs, we want to make sure that we are prioritizing and looking at those red flags for medications, okay? Blood thinners, like you were saying, Eliquis, our warfarin, our insulins, right? Our inhalers. When we are doing our med rec and we're seeing something that seems off, these are what we need to flag. This is this looks like a problem. You haven't taken this. You're taking double of these. Something's missing, something's broken. It's time to do that handoff, okay? All right, in closing we want to close the loop with medical groups and providers. All right, so how do we do that? In our med recs, depending on what type of EHR systems we're using, we have to make sure we're leaving the most detailed notes, right? Who did you call? Who did you speak to? What did they say? What did the patient actually say? What did the doctor confirm? What did the other pharmacy confirm? The better the notes we leave, the better the communication. Because I don't know about y'all, but I've never, even being in the systems that I've worked in, I've never been able to pick up the phone and the doctor actually picks up at that moment to relay that information. It always has to be through a chain of command. Am I correct? Now, I would love to have every doctor on speed dial, even working in the ED. Do you ever talk to your doctors directly in the moment you need to, or you got to wait? I would love to. But since we know that can't happen, the better we document, the clearer that communication is, okay? And then when we have access, we want to make sure we're deactivating when we have confirm is no longer taken, right? This way, even if it's just one person that we are able to make whole per day, that's one person that doesn't fall through the crack, right? And that's making an impact. Because as much as we want to go in, especially with MedRex, as much as we want to go in and make every patient whole, have a complete picture, that doesn't happen. Pharmacy is closed for lunch. We have to confirm with the doctor that's on vacation for 2 weeks. It happens. And then by the time we get off our shift, that handoff, that patient is moved around in the hospital or has been discharged. So we gotta, even if we can do one, I'll take it. I'll take the one. All right, is anybody familiar with stars ratings? Isn't that fun? They make stars. The way they make stars sound, it should be good, right?
You're making me cry.
I know. No. I want stars ratings to be like it is. It is a good thing. It's just hard to get to that point, and we know that, and it's because of what we were just talking about. It's hard to connect all the dots with all the people, and when we're trying to focus on patient care, and if what we're doing is actually working, there has to be a measure. Checks and balances, right? So for those who don't know, a stars rating are quality measure system used by CMS to evaluate Medicare health plans based on performance and outcomes. It matters in reconciliation. It measures the medication adherence for statins, diabetes, and blood pressure medications. So we could do everything right. They could fill exactly every 30 days or every 90 days. We can ask for that 90-day supply. The moment one thing falls, one thing. Oh, I went on vacation. I didn't need those. I didn't take them for a week. I forgot. I was feeling fine. How many of y'all heard that? They take it for 1 week. The next week they feel amazing. So they stop taking it. And now you have 150 pills left. And now we're back in the ER for something we should have been taking every day. Just for sustainability, right? And then it impacts the plan funding and bonuses and reflects patient health outcomes and safety, okay? This means that medication reconciliation directly impacts these scores. So, again, when I stepped into the pharmacy, typing my prescriptions in the middle of the night, not knowing what I was talking about or what I was doing or how important it was, I never knew that it would be at this point, right? Where it's impacting not just our patient safety, the outcomes, but the funding for their plans. Right. Why techs are the real MVPs? It's us. We are, for sure. I don't know about y'all, but I remember when I first got my, they passed the bill during COVID. Wonderful world of COVID. I don't know about y'all, but I was doing COVID testing. Yes. And then we were able to do vaccines. I don't know, but I never thought that we'd be doing vaccines. Am I tripping? Am I great? Did you ever think that after typing a prescription you'd be doing a vaccine? No, I'm like, is this for real? Are they going to change their mind tomorrow? Like, just kidding. I thought it was very, very cool. And I say that because it just shows that being a pharmacy technician means that we really can do anything. I do. And I think we take it all on. Because on top of giving vaccines, we were making sure our fast track was in order. We were making sure that we were doing counts. We were making sure everything with our safes counts were right. We were ordering. We were doing inventory all at one time. And building reports with our patients. Not getting cussed out every day. That's a win. All right, so PDC is proportion of days covered. We keep patients adherent by solving the root causes of their barriers, right? Asking the right questions. Detective work. We are trying to reduce hospital readmissions. Oh, catching Mr. Frank's duplicate therapy. As soon as you see this field, especially Mr. Frank, who we probably saw every week anyway, because that's when he's coming to get his supplements that he may or may not be taking, or his scratch-offs, or he's coming to get his snacks, or he's coming to get his toiletry, foot cream, everything. We're going to see him every week. We notice something like, oh, I never seen you take this one. Let's catch that, right? And then the member experience. Patients remember the tech who helped them afford their inhaler. They do. And now you better be able to fix everything. Am I right? Aren't they? Nope, I need to see Asia. 2 years ago, I had this inhaler, she fixed it. So now lisinopril can't be filled without Asia. Oh, wait, come on. Asia not there, I'm not picking it up today. Lord, it's ready though, come on. But Asia, no, thank you, we seen that. And we love that relationship, right? We love those relationships. Okay, so some key takeaways. Data is the guide, but it's not the gospel. What we see in our claims, what we see in our lists, the bottles that we see, it is just pieces of the picture until we find out what consumption looks like. Right? And we're not in the house with them. So we can never say it's 100% until we can see them actually and we're not their caregivers, right? Formularies drives behavior. So we want to anticipate any type of confusion. So like Roxanne, what you said, if there is a new change to go back to this donut hole, it's better to start educating our members when we start hearing that. So hey, I want to let you know this could be happening soon. Let's get ahead of it so we don't miss anything, right? And we save lives. Our communication, our investigation, and our coordination are critical to patient safety. I have only made one mistake in my 17 years. And when I say mistake, I mean just selling the wrong medication. It only took one. It only took one. And I don't even think it was anything major, but it only takes one to be that nervous about a situation, you know? And it's like we care so much, we never want. Because it could have been called like, hey, at home, they're going to call us anyway. But like, hey, before you take that, I need you to double check. But we do save lives, and I think that with that one mistake, it keeps us human and humble. And now we never not pay attention, right? I wanted to make sure I answered any questions anybody may have, and then I have some references here for further.
Okay, I have one.
Yes.
I can't believe you remember that donut question.
I know that donut.
When I asked what the donut was. I just would like to add something. My local fire department, bless their heart, there's one chief that took to heart. He, and you can maybe ask your fire departments around, he made a sheet with point of contact and all the medication stuff. And it's in a folder, and it's in a magnet, and it sticks to the refrigerator. And he gave me over 200 to pass out to my customers. They also hit all the assisted living and nursing homes, so they already have that list. So you might suggest for them, it was the Papillion Fire Department in Nebraska that took the initiative on there to do that.
That is so smart. That's,
you know, think about it as a paramedic. I'm walking into, I have an unconscious patient. Where is their drug list? Do I really want to grab all those bottles and put them in a bag and take them with them? Well, I'll do that, but I'll also grab that list off the refrigerator.
Off the refrigerator. That actually is so smart. And I think if it's in a place where it can be seen, as soon as it's kind of a reminder where to either cross something off or where to add something.
And if a paramedic, if the fire department is telling an elderly person to do this,
they will listen.
They consider that as the
gospel.
That is the authority.
They went to the assisted living. This chief literally went to all the assisted livings in the area and handed out to the patients and their families to do this.
And then all of the fire department knows the first place you check is the
refrigerator. Oh my goodness.
And it has a list of drugs, and it also has the emergency point of contact, and their sell point is, if you can't talk to me, this can.
I love that.
That's amazing.
That is very cool to work with your local fire department. I love that.
And I saw that, and I said, I got people living at home alone. Give me some. And I literally handed them out I ran out at the pharmacy.
I'm sure you could make a copy, but you're right. If a fire
it's like 2 or 3 pages, but it's in a plastic container with a magnet and a big red thing on the front.
I can visualize
the fire
this.
department looks for it.
Yes, that is very, 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 very cool. that gives us an idea where we all, no matter what state we're in.
Yeah.
I mean, talking to our fire department, we're gonna do this anyway because a lot of our patients are picked up by the fire department sometime when it comes to needing to be transported, right?
Right.
But also the way that we dispose of our medication, depending on how your state is. So let's just take Mr. Frank for example. Mr. Frank is now going to be taking the Jardiance instead of his Farxiga. Yes, it was expensive, but for something helpful for Mr. Frank, just so he's not double dipping, probably needs to get rid of it. We
Well,
do
you
not.
can give him one of those mail self mail
Yeah, and
envelopes.
And they do drop off days. I know sometimes at local fire departments. What we don't want them to do is flush it, which he probably been doing for the past 40 years.
Right.
Please don't flush it. We gotta drink that water.
My old pharmacy had the bin.
Yep,
And
mine did too.
we were like, you can either leave it in the bottles, we don't look at the names, or a lot of, especially really old people, tend to put all of them in Ziploc bags
Yeah,
because they don't want their information.
they don't want their information out.
It's like, bring the bag.
Yes, just we'll take it. Just don't take them at home. Just don't, or put them in the wrong hands. You know.
But there is a system where you don't have to pay postage.
Yes.
Because we can't dispose of narcs.
Nope.
We just hand them an envelope and they just throw it in like a postage mail and it gets that way too.
Yeah, and I think that us pushing our patients and members of our pharmacy to actually dispose of the medication, but that hoarding is where the bad part is. Because now we have 5 years worth of the same drug. It has changed, frequency has changed, and shelf life. Like that expired 2.5 years ago. I hope you're not taking this, you know?
Well,